Hello, welcome to this ICS live event. The subject today is the challenges of urethral stricture in women. Today, I will be presenting. My name is Lisanne Campo. I'm an associate professor at McGill University and a urologist at the Montreal Jewish General Hospital. And I will be co-presenting with my colleague, Dr. Jacques Corcos, who's a professor of surgery at McGill University and also a colleague of mine as a urologist at the Jewish General Hospital. So we welcome you to join the discussion and ask us questions via the comments functionality, which you'll find next to the About section on the page you are watching right now. You can leave your questions now and we'll answer them when we can, most likely at the end of the session. If you are watching this back, not live, you can still leave your questions and these will be picked up by the faculty at a later time point. So we'll begin with Dr. Corcos. Thank you.
Good morning or good afternoon, depending where you are in the world. Welcome to this new session, ICS new session, live session. So first of all, either Dr. Campo or myself will have anything to disclose for these presentations. So we're going to talk about these strictures, urethral stricture in women, which is definitely a challenging problem. First of all, in terms of definition, a stricture is a fixed symptomatic anatomic narrowing of the urethra. So each word is important, obviously, in this definition. Symptomatic and anatomic narrowing is important, fixed, meaning exactly at a certain point. There is another definition, which is in fact the fact that you cannot put any instrument in the urethra, any instrument up to 12, 14 French. If you cannot pass that, there is definitely a narrowing of the urethra. This is a rare event. When you look at the overall bladder outlet obstruction in women, which is already not a very common situation, you can, among these bladder outlet obstruction, only 7 to 20% of them are related to an urethral stricture. And if you are looking only to patients complaining of voiding LUTs, you realize that it represents only 0.1 to 1% of overall strictures. So I think that this is a rare event, but when you are facing it, it's definitely something that you have to take care of and that you have to understand well to take the best treatment option. So how does it happen? First of all, it requires an ischemic urethral insult with scar formation and narrowing as a scar to get a narrowing of the urethra. The causes are mainly iatrogenic, and we're going to come back to these iatrogenic causes. It represents 88% of female strictures, but you have also some infections, cystitis, urethritis. It could be idiopathic. Rarely, you cannot find any reason, but the stricture exists. It could be traumatic, mainly gynecological, after prolonged labor, straddle injury, pelvic fracture, you can see the strictures. And even more rarely, it could be related to tuberculosis, lichen sclerosis, vaginal carcinoma, or local advanced cervical carcinoma, or simply a small fibroepithelial polyp. So the causes are multiple, but again, most of the time they are iatrogenic. What are the maneuvers? What are the reasons why this stricture occurs after treatments? Number one, prolonged catheterization, repeat instrumentation, cystoscopy, bladder tumor resections, some urological procedures like diverticulectomy, sling procedures, transvaginal transvaginal fistula repair. It can happen after simple delivery, again, maybe not everywhere, but in some countries. related to the length of the delivery, pelvic radiation, and urethral dilatation, which is still used for some voided dysfunction. So before going to the anatomy, reminding just to tell you the main differential diagnosis with these strictures is dysfunctional voiding, Furrow syndrome, dysfunctional voidings. Most of the time when you see a patient, a woman complaining of difficulty voiding, straining to urinate, you have to eliminate an anatomical structure, but most of the time it's not anatomical, it's more functional, it's a spastic pelvic floor, a stricture provoked simply by the contraction of the sphincter, and this is the main differential diagnosis. Just a quick reminder of the anatomy of the urethra. On the right side, you can see the urethra, the female urethra, which is usually 2.5 to 3 centimeters long, which is the lining is the epithelial, classical epithelial lining, urethral lining, surrounded by a layer of rich venous plexus. Around it, you have two kinds of muscles. You have a circular muscle and longitudinal muscle, and that you can see on this cut here, when you have the circular coat first and the longitudinal coat. At 2/3 of the urethra, you have this increased size of the muscular tissue, which creates what we call the external sphincter. And finally, right beside the meatus, you have this collagen ring, which is creating a virtual compression of the urethra in order to avoid the penetration of bacteria, penetration of different kind of external dangers. If you take a more global view of the urethra, this is a vaginal wall, this is urethra. The only thing which is important to notice are these glands, the skin glands surrounding the urethra on each side and providing to the urethra the secretions which create this a better fluidity, a better function of the urethra. Now, how do you assess clinically these patients? The symptoms are completely non-specific. Usually, the patients are complaining for poor flow, incomplete emptying, straining, sometimes urinary retention in advanced cases, frequency, nocturia, painful micturition, pain, urgency, and sometimes recurrent infection. So as you can see, there is nothing specific, but in front of one or two of these symptoms, the first diagnosis must be an anatomical stricture because there is no, it's relatively easy to make the diagnosis. The second diagnosis, as I mentioned before, is dysfunctional voiding and functional spastic urethra or pelvic floor, including the sphincter. The physical examination, the classical vaginal examination, usually doesn't reveal too much. Exceptionally, you can see a meatal stricture. You can see some lichen sclerosis. Lichen sclerosis is important because sometimes the lichen sclerosis extends inside of the urethra, creating some stricture itself. You can obviously have some prolapse, which is important to assess considering the future treatment. You can have some periurethral abnormality, which is always important in case of cancer, cancer of the urethra, cancer of the vagina. And again, the inability to pass a 14 French Foley catheter is relatively pathognomonic of an anatomical stricture. In functional stricture, usually after a couple of trials, you are able to go through, but it is not the best way of differentiating between both. But it's important to know that with the stricture, usually you are not able to put a catheter, 14 French catheter. So again, it's important to assess the whole area, the whole pelvic area, including the inside of the vagina, in the consideration of future surgery. So what are the investigations to do? The simplest is a urethral and the PVR, cystoscopy, ultrasonography, cystogram, video urodynamic, MRI. We're going to go back to each of these. So the uroflowmetry and PVR, this is a typical completely flat flowmetry of somebody pushing and having a very, very poor flow. So a very severe stricture here. And this is usually associated with a flow below 12 to 15 milliliter per second, and the PVR above 100 cc's. Cystoscopy is useful, not always possible. Sometimes the stricture is very distal. When it's very distal, it's difficult, or if you have a metal stricture associated with, it's impossible to put a cystoscope, even the smallest one. It can give you a good idea that there is a stricture. It cannot really tell you the length of the stricture. Ultrasonography, vaginal ultrasonography could be helpful. Not so easy to see the stricture. It's recommended to inject some gel into the meatus in order to make the urethra even more hypoechoic. And you can see, like on this picture, a narrowing, a relatively distal narrowing of the urethra. The voiding cystogram is probably the best test. It's not always possible because you cannot always access the bladder, but if you can always put a small 5 French catheter in the bladder, fill it with dye, and you can see the location of the stricture with the balloonization of the bladder neck. This is dilatation of the bladder neck. You can see sometimes some diverticulum. Maybe there is one here, I'm not completely sure, but the bladder has definitely an abnormal shape, irregular, and you think about a trabeculated bladder in case like that. So these are the findings of the cystogram. If you do a video urodynamic, it will give you the same cystogram, plus it will give you the pressures. Usually the voiding pressure is high. In this case, you have a very flat very flat flow, but the pressure is not extremely high. But you can see on the picture itself that there is again a dilatation of the urethra, which is definitely not normal with an opening of the bladder neck. So the video urodynamic is helpful, give you at the same time the voiding pressure and an anatomical description. Is the MRI a good test for stricture? Unfortunately, no. It doesn't really give you a picture, a good image of the stricture itself. It gives you an idea of the surrounding tissues, and it's important, again, to plan for surgery. So the urethral diverticulum can be seen. You can have some periurethral fibrosis, can be seen, not always possible. You can see some abscesses because there is some fistulas, always possible with a stricture. And obviously, it's extremely useful for malignancies, cervical malignancy, urethral, vaginal malignancies. This is definitely the best tool to see these malignancies. So if we try to summarize the investigation, the diagnosis is mainly driven by the symptoms. You suspect the symptoms by interrogation, by physical examination, you can really come very close. UDS is sometimes misleading because the bladder can compensate for a while and you can still have a good flow with a relatively poor, good residual in these cases until it really blocks completely or partially. The extensive imaging evaluation is necessary to plan for the best treatment. And here I'm thinking about cystogram, obviously, and MRI. So thank you for this first part, and I will be willing to answer any question at the end of the presentation. And I'm going to give the screen to Dr. Campo to talk about the treatment of the strictures. Thank you.
Great. Thank you very much, Dr. Korkos. Before I move on to the treatment options, I just want to remind the audience to please, if you have any questions or comments, please go ahead and put them up on the ICS live website. Okay, now we will discuss the different treatment options available to address female urethral strictures. And Dr. Korkos gave us a wonderful overview of the underlying etiologies, the pathophysiology of it, and how to investigate them. And I think what's very important to take from his talk is that planning is very important. All these investigations will allow better planning in order to provide the patient with one treatment that will give her the longest success rates and over time. Now, the treatment options range from minimally invasive treatments such as urethral dilatation or optical urethrotomy or direct vision internal urethrotomy. And the surgical treatments are in the form of either a myetoplasty or urethroplasties. The urethroplasties can be done either using flaps or several different types of grafts. And I'll walk you through all these different options and important aspects to consider for each one of them. Now, urethral dilatation is often used as the first initial treatment for women with strictures. And it's often done at the same time of diagnosis. So oftentimes patients will be diagnosed at the time of a cystoscopy. And because of their symptoms, then a urethral dilatation will be done concomitantly. Dilatation can be done with female sounds up to fairly large calibers, and this can be done only if you can obviously cannulate the urethra, and it can also be done with filiform followers and many different types of dilators. Success rates range from 5 to 50% recurrence within 6 to 12 months. So that's not a wonderful success rate. And the wide range seen is that first of all, there's high recurrence rate, but the range is also attributed to the significantly lower success rates found with subsequent dilatations. So I often will not perform more than one urethral dilatation, considering the poor success rates that occur after one failed dilatation. Now, there's limited evidence that doing self-catheterization following the initial dilatation could maintain an open urethra, but it's something that can be considered for patients, for women who are open to the idea of catheterizing themselves. And it can therefore provide better success rates. This can be initially done daily and therefore decrease the frequency after a few months. Now, the second endoscopic procedure is the optical urethrotomy or direct vision internal urethrotomy as well. The evidence for this procedure in the literature it's even more scarce for particularly our patient population, our female urethral stricture patient population. However, the principles are similar to what is done in the male, which is obviously much more described. And the modality can be done using either cold knife or a Holmium laser. And the incision is done in the lateral portions of the urethra, therefore at 3 and 9 o'clock position. Now, if it's needed because of also an anterior or dorsal component, at 12 o'clock incision can also be done. There's some people who've described doing a cut through the light portion if there's complete obliteration in the setting where you have an SP access and you can have an antegrade scope to provide a light. Now, some people have described that following the endoscopic or the optical urethrotomy, a Foley catheter should be maintained for several weeks, and a repeat cystoscopy should be done to ensure proper epithelialization. And because of the scarcity of this technique for our patient population, there's really no long-term data on efficacy and complication. And personally, this is a procedure that I very rarely do. Now, if the stricture is involving only the meatus, and that's sometimes the case, and it's only involving the meatus for a short distance, so we're talking about 5 millimeters, a meatotomy can provide reasonable success rates. Ventral meatotomy is performed by doing first an incision along the ventral meatus, and so just for to orient our audience. Most of us are familiar with the ventral and dorsal portion of the urethra in male, but for women sometimes it's less commonly used as a descriptor. But the dorsal portion is the portion of the urethra between the clitoris and the urethra, and the ventral portion is the portion between the urethra and the vagina. So the ventral portion is where the anterior vaginal wall sits. Now, the meatotomy is done by first making an incision, a ventral incision along the meatus until a normal lumen is reached. And when we say a normal lumen, you want to have a caliber approximately of 20 French. Then the meatotomy is done in a Heineke-Mikulicz fashion. So this is the principle of the Heineke-Mikulicz, which has been very often described for meatotomy in men. But the idea is that after the incision is made, the edges are then sewn transversely by approximating the urethral mucosa to the vaginal mucosa, and this is done with interrupted suture. So this will create a slightly hypostatic urethra, which may involve also a risk of spraying or vaginal voiding. So that's something to consider. But oftentimes the incision is not for a very long portion. It's for a few millimeters, so it's minimal. Now, in order to have a good success rate, the quality of the vaginal mucosa is very critical here, and for many other techniques that we'll be discussing in the next few slides. And so this technique should therefore be avoided in cases of lichen sclerosis or severe vaginal atrophy. I've had experience in women in patients who've had significant vaginal atrophy that I will use a vaginal estrogen and not necessarily the tablets, but the cream following following a meatotomy in order to maintain good quality vaginal mucosa to prevent recurrence. Now, a different meatal reconstruction option involves doing a distal urethrectomy with an advancement meatoplasty. Now, this should only be entertained in case where the distal meatal stenosis involves only 7.5 millimeters. So you can do this meatoplasty if the stricture involves a little bit more than the meatotomy, but not that much more. So this technique is done with by doing initially a circumferential excision of the stenosed meatus. So the entire stenosed portion of the meatus is removed, and there's subsequent mobilization of the proximal urethra. Now, it involves making a new meatus by creating it with interrupted suture between the urethral edges and the vaginal mucosa. Now, similarly to the previous technique, the vaginal mucosa is really critical and should be healthy to prevent recurrences. And the literature really doesn't provide any significant reported outcomes with this technique. So. Now, let's look at the different urethroplasty techniques that have been described and that are used. The first few ones that I'll describe are primarily flap-based techniques. And this is important to make the difference between the flap-based techniques and the graft-based urethroplasty. So the next, I believe, 8 to 10 slides are all flap-based urethroplasty. Vaginal flaps are an attractive method as they are usually well vascularized, and they can be mostly freely mobile, and therefore can yield fairly good results with lowest morbidity to the vaginal wall flap. To the vaginal wall. Now, the advantage of using flaps versus using grafts, well, is that you're operating locally and you're not using a graft from another portion of the body. Now, for example, when using grafts such as buccal mucosa or lingual grafts, there's an additional morbidity that needs to be considered if you're planning to do this procedure. But we'll talk more a little bit later after for the grafts options. Now, the anterior vaginal flap is also known as the Blandy urethroplasty. It's been very commonly described, and it's likely the one of most commonly known and used by reconstructive surgeons. It can be used to treat more distal strictures that involve 1.5 to 2 centimeter of the distal urethra. So you can use it for a fairly good portion of the distal urethra. It can be done with an inverted U-shaped incision over the ventral urethra, and the flap that's created is approximately 3 centimeter long. Now, once the flap is, when making the flap that's 3 centimeter long, it's important to preserve the submucosal layer containing the vascular pedicle of this flap. The ventral side of the urethra is then incised until healthy proximal urethral mucosa is identified. And again, healthy urethra is something that can accommodate at least a 20 French catheter. Stay sutures are then placed on both sides of the open urethra in order to facilitate exposure. And the flap, basically, once it's created, will be turned inside towards the open urethra. And the tip of the U-flap is then sutured to the apex of the open urethra on the ventral aspect. So this therefore creates a slightly hypostatic urethra, and also therefore has a risk of inward urine stream and with vaginal voiding. Now, like I said, this is a very commonly used flap. It's been very well described in the literature. The success rates vary between 89% and 91% over a few years of follow-up. And it has, what's interesting about this what's attractive about this option is that it makes sense the way that it's made. It's kind of easy to conceptualize for many surgeons, particularly reconstructive surgeons, and it has minimal morbidity for the patients as well, along with good success rates. Now, the next flap technique here described and published is the dorsal vestibular flap, and it's also called the Montorsi flap. So this flap will use vestibular tissue, and the vestibule, if you remember, is really just at the opening of the vaginal mucosa, of the vagina, very close to where the hymen was previously, the hymenal ring is placed. Now, an inverted Y incision is made at the dorsal urethral meatus, and you can see up over here, this incision is done on both sides. This allows the distal urethra to be dissected away from the clitoris and the surrounding suburethral tissue without accessing the ventral urethrovaginal portion. So the plane between the vagina and the urethra is kept intact. It's only dissected on the dorsal aspect here. Once the urethra has been mobilized, the strictured urethra is then opened, and usually from the meatus onward. Now, all these flaps are primarily for distal stricture again. You want to open the urethra until you reach healthy mucosa, again, reaching approximately 20 French caliber. Now, according to the length of the stricture, you can have between 1.5 to 3 centimeter long flap. Now, when we talk about this length, this is the length from the tip of the flap, which is here, located here, to the entire length is here, and it can be fashioned according to the length of your stricture that you have. It can be done from either the right side or the left side, and just beside the vertical vestibular incision. So this flap has a rich blood supply, and it's important because it's needed. So therefore, you have to avoid doing too much superficial submucosal dissection. So you want a good flap, a good, thick, well-vascularized flap, and you don't want to be thin on the mucosa. Now, the tip of the flap, which is seen here, is then anastomosed, and you can see it on this image. It's inverted inwards, and the tip of the flap will be anastomosed again to the apex of your opened urethra, which is open on the dorsal aspect. And so it's by inverting it inwards, and then you continue the repair with interrupted sutures. Most of the repairs that have the flap-based repairs that have been described are done with interrupted sutures, and you want to use dissolvable sutures. I personally use PDS, so a small PDS suture, because I find that the monofilament preserves the tissue or the integrity of the tissue a little bit more. Now, this technique has fairly good success rates, about 88% that has been described in the literature over a year. But like all the other flaps like most flaps, there's a risk of a spraying or deflection of the urinary stream here. Another flap here that has been described that uses the vestibule, which is slightly different than the previous one, than the Montorsi flap, is the lateral vestibular flap. It's also known as the Zimmer flap. It's primarily used for distal urethral stricture, and also you can cover approximately 2 centimeters of stricture in this with this flap. So the laterally based vestibular flap is created first, followed by a lateral urethral incision and dissection and excision of the fibrotic ring. So if you notice here, once your flap is done, at the level of the urethra, you'll you can only do an incision of your urethra, or you can remove, if there's significant fibrotic tissue, remove a portion in order to replace it with healthy vestibular flap tissue. Now, the success rate described here for this technique is slightly lower than the other flaps, but they also have a slightly longer follow-up, again, with the risk of spraying and deflection of the stream. So the lateral vaginal flap here is also described as the Orandi flap. It's basically inspired by the male urethroplasty technique. So this lateral vaginal wall flap involves doing a midline ventral incision along the vaginal wall, or you can also do a slightly C-based incision as well. And what's interesting about this Orandi flap is that it can allow coverage for variable length of strictures, and it can also provide a more proximal coverage than the previous flaps described. So again, what's interesting about this particular is that it's a flap base, so not a graft base, but you can still cover a proximal urethral stricture a little bit more than the ones I've just described. As I mentioned, it's inspired by the ventral longitudinal island penile skin flap in male urethroplasty and hypospadias reconstruction. Now, the ventral urethra, following the midline incision, the ventral urethra is incised at the level of the stricture until healthy proximal urethra is encountered. Then a 2 centimeter wide flap with depending on the length of your stricture, with an adjusted length, is harvested from the lateral vaginal wall. Again, it can be done on the right or left. But here, the dissection is quite important. So medially here, the dissection of the flap is performed fairly deep along the periurethral tissue, because you want your flap vasculature will be based from this medial dissection. Laterally, the dissection is done along a more superficial submucosal plane. So your flap is primarily based off of here on the medial portion. Now, after dissection, mobilization of the pedicle must be done sufficiently in order to allow the mucosal flap to be turned inwards. And you can see on this picture, you always want the mucosa side to be facing the lumen of the urethra. And so you want the mucosal flap to be able to be turned and sutured into the open urethra. If hemostasis is needed, I usually use bipolar hemostasis in order to prevent devascularization as much as possible. And therefore, the medial portion, which is here underneath, the medial portion is then sutured towards the ipsilateral side of the urethra, and therefore the mucosal surface of the flap is turned towards the lumen, and the initial lateral side, which was here, is sutured on the contralateral side of the urethra. So what's nice about this flap, again, is you can have a longer coverage of urethra, and there's very high success rate with this approach. Now, the labial flap is another option for a flap. What's different about this flap is that it's based off of a pedicle, which is different than the previous flap that I've just described, the Orandi, the Montorsi, the Blandi. Those are all, they're not pedicled flap. They're flaps that are, the base is intact from the mucosa. Here, the labial flap, it can be done either from the labia minora or the majora, and again, placed on the pedicle, and then it's passed in a tunneling fashion underneath the vaginal mucosa. And also what's nice about this option is that you can have a variable length of coverage. Again, the success rates are quite good, 82% over 2 years. And so this is also a reasonable option to have a longer coverage with a flap-based technique. Now, all of these flaps are reasonable treatment options to consider if the vaginal mucosa is healthy and free of significant atrophy or lichen sclerosis. So that's really important to consider, particularly if the patients are postmenopausal and are therefore more at risk of developing vaginal atrophy or possible lichen sclerosis within that age group. Now, if the vaginal mucosa is not healthy, and it could be not healthy for other reasons besides vaginal atrophy, it could be post-radiation. Some women may have a very narrow vaginal introitus as well, which could prevent having enough tissue in order to do these flap techniques. So otherwise, if these flaps are not an option, then grafts from elsewhere must be harvested for repair, such as buccal mucosa or lingual grafts. Now moving on to graft urethroplasty. So several grafts have been described in female urethroplasty, such as vaginal mucosa. So again, the graft can be used from the vestibule, can be used from the vaginal mucosa. It can also be used from the labial mucosa, again, labia minora, labia majora. But this is all local grafts. Again, in order to use grafts from vagina or labia, you need to have healthy tissue in that area. Otherwise, you may need to use a graft from the oral mucosa, and this can be done either from the buccal or lingual mucosa. Most of the literature is described using buccal mucosa because there's extensive literature also for male urethroplasty using buccal mucosa. Now, the urethroplasty, in order to be successful with a graft, requires an adequate imbibition and inoculation. So your graft needs to take, basically. And so the technique is particularly important for your graft to hold well. You need to have a vascularized bed. So the graft requires suturing onto a well-vascularized graft bed, and the graft itself needs to be carefully defatted. Now, the approach for grafting can be done in a dorsal onlay approach or a ventral inlay approach. Now, most of the study, well, there's studies that have been described for both approaches, but the dorsal onlay has significantly more studies describing it. Now let's look at the dorsal onlay graft urethroplasty. So I personally have experience with this approach, and I've had very good outcomes. There is some people stay away from this approach because of the fear of injuring the clitoris, the nerves, and the vascular tissue. But it's as seen in the literature, it's a very theoretical risk, and it's extremely rare. Now, so the dorsal onlay graft urethroplasty is done by initially making a semilunar suprameatal incision, and then by dissecting the plane between the urethra and clitoris. And you can use the pubic bone, you can palpate the pubic bone in order to mark the point of the most proximal dissection. Again, it also depends on the length of the urethra. I will often use this technique when the stricture of the stricture of the urethra is involving most of the urethra. So if it's only a distal stricture, I can use a local flap. I will use a local flap, but I'll talk a little bit more about how to select the best treatment options in a moment. So the dorsal urethra, after dissecting it through this plane, is incised, and the stricture is opened along either a guide wire, and then you want to encounter a good caliber and healthy urethra. Now, once you have a good idea of the length of the stricture, you want to go harvest the graft of adequate length. And the graft will be placed, again, with the mucosal surface towards the urethral lumen. And the edges of the graft will be sutured to the edges of the opened urethra with so you can use either a running or interrupted fashion. I usually start suturing at the level of the proximal urethra and continue on to the meatus. Now, what's particularly important with this dorsal onlay graft urethroplasty is the quilting of the graft to the clitoral bodies in the midline with resorbable sutures. So what you see here is that it's not freely standing. Actually, once you place your graft here, you want to really quilt it along this plane so that it has a good vascular bed. And I think that's really critical in order to ensure a good success rate. And again, you can use, again, interrupted suture at the level of the meatus as well. So success rates are quite good. This is a range, but I'll show you some more data about a meta-analysis looking at the results. It might be a little bit more technically challenging than the ventral graft. However, I find that it provides very good results as well. Okay, now let's look at the other approach for the graft urethroplasty, which is the ventral inlay graft urethroplasty. So this involves doing a midline vaginal incision along the urethra, and then dissecting the urethra on the ventral portion between 3 and 9 o'clock. Now, the urethra is then open on a ventral midline, doing a stricturotomy, and it can be started from the distal aspect until a healthy urethral mucosa is encountered. And it's important to have a good spatulation of the urethra as well at this point. Once you know how long of a stricture you have, then you can harvest your graft accordingly. And here, again, what's important here on the ventral aspect is having a good bed, for a good vascularized bed for your graft. And as you can understand here, there is you don't have the same vasculature that you have on the dorsal aspect and on the ventral aspect. So you can use the spongiosal tissue, the surrounding spongiosal tissue around your urethra to provide a vascular bed. But sometimes that's not sufficient. And you may want to harvest a Marshall's flap from the vagina in order to place it against this against the graft in order to provide a better vascularized bed. So a healthier vascularized bed. So it's thought to be slightly easier than the dorsal graft because you don't have to dissect between the clitoris and the urethra. However, there are some higher risk of fistula formation and graft sacculation because, as you can imagine, you're very thin. You're right from in the vagina, so there's not a lot of tissue preventing these possible complications. If there is a concern for incontinence, you can also do a concomitant fascial sling at the time of a Marshall's flap as well. Now, I want to share with you the results of this well-done recent systematic review and meta-analysis done by Serin et al., published in January 2021 in neurourology and neurodynamics. And so they looked at the different management modalities for female urethral stricture. So they reviewed the evidence in the literature of over 550 women from 28 different relevant studies. And here I wanted to show you this table looking at the success rates. And so you can look at the different flap urethroplasty and the different vaginal graft urethroplasty, and the success rates are fairly similar. Now the follow-up is variable, but it's difficult to say that one is superior to the other, really. So now you have to think that this approach is oftentimes individualized for each patient. And so, not all of these patients in these studies are necessarily equal. They may have different length of stricture, et cetera. But what this tells us is that in the literature, the selection of the treatment for each patient has been providing fairly good success rate. Now, what stands out here is the urethral dilatation. We know the success rate is fairly low, 50%. But as I mentioned, it can be used as an initial first time and only time treatment options. Now, how to select which procedure. So there's certain factors you'd want to consider. You want to consider what are you familiar with, what approach are you comfortable with, and sometimes it can be nice to pair yourself with a surgeon that may have done more urethral reconstruction in men, and using your expertise for women, combining this expertise may be a nice alternative to consider. You have to consider the length of the stricture and also the cause of the stricture. Now, if it's the first, this is a first treatment and it's a short stricture, then dilatation or direct vaginal urethrotomy could be considered. If it's not first treatment or a short stricture, I would consider alternatives. Now, my first question is, can a local flap or possibly a graft to be used? And so I want to look at the condition of the vaginal mucosa. So I will avoid local flaps or grafts in settings of lichen sclerosis, or significant vaginal atrophy, history of radiation, or if the vagina is fairly scarred and there's a narrow introitus that would prevent proper exposure, such as in patients who've had significant vaginal surgeries, prolapse or colpoplysis, etc. Now, which procedure to use? Well, you have to consider the length of the stricture and the location of the stricture also. Now, if it's a short distal stricture, less than 2 centimeter, depending on if it's a small, again, less than 5 or 7 millimeter, a meatotomy could be considered. If it's less than 2 centimeter, if it's between 5 millimeter and 20 millimeter, then the vaginal wall flaps or the vestibular flaps might be interesting. If it's a long stricture, the dorsal vestibular flap or the lateral vaginal flap, which is the Orandi flap I described, could be considered, or the labial flap as well, but also the dorsal grafts and the ventral graft. And again, here you have to consider, is the vaginal mucosa healthy? Can I use a flap? Otherwise, then you will have to use a graft and possibly, and obviously use a graft from elsewhere in the body. Now, the patients are poor surgical candidates. Sometimes you don't have an option but to revert to dilatation, to repeat dilatation, urethrotomy, and possibly with intermittent self-dilatation, or even to consider a diversion. Thank you. So I'll let Dr. Korkus to conclude our presentation.
Thank you, Lisanne. I think it was an amazing review of the different treatments. As you realize, there is not one technique better than another one. If you exclude, obviously, the urethral dilatation, all the techniques seems to have approximately the same results. Definitely, it's the experience of the surgeon, the best surgeries that you know, the one that you are used to do is probably the best to realize. And it's important to really plan properly and to explain properly to the patient what we're going to do, because it doesn't work always so well. And if you have complications, if you have fistulas, if you have to redo your surgery, it's important that the patient is part of the whole treatment, like for any kind of treatment, obviously. But this is important because this is difficult. It's not something simple to do. I will not encourage everybody to jump on this kind of surgery without any experience. I think that it needs formal training, and it needs a lot of experience to be able to reach this level of results. So if you're interested, contact your different surgeons. As Lisanne mentioned, there is a much more experience in male reconstruction. Male reconstruction surgeons usually have good techniques and have tried a lot of techniques and can help you. Your expertise in vaginal surgery is definitely going to allow the dissection, and the expertise of your colleagues are going to allow you to reach this level of good results. So thank you for listening. Thank you for asking questions. If you have any question, we're definitely here to answer. It was a pleasure to express our to share our experience with these techniques. And thank you to everybody, and thank you to ICS for organizing these conferences.
Thank you. So I think we have a few minutes to answer some questions. There's been some comments. So Dr. De Castro asked whether if we believe in the existence of female bladder neck sclerosis, or I also call it primary bladder neck obstruction in women. I believe there is an entity such as that, and I consider it quite different than a stricture. So it's a different topic altogether. But it's known to be more of a functional diagnosis of bladder neck that is not open properly. I don't know, Dr. Korkus, if you have any experience with that.
Well, I'm assuming that you're talking about this patient. Usually relatively old, who come on a yearly basis or even more often for the urethral dilatation that we have seen for years, treated by older urologists. And we cannot exclude that there is no, in this patient very often, we cannot really find a real stricture, but there is rigidity of the urethra. And obviously, to continue doing catheterization or to doing dilatation is one of the options. But usually, we prefer to offer uretroplasty to this patient to stop this kind of vicious circle where you create more fibrosis by doing dilatation. And the treatment is, surgical treatment is probably better.
For the patients who have like a true primary bladder neck obstruction, I have done bladder neck incisions in women, and and all this, all the while preserving their incontinence. So so that's something that I offer. But before offering a bladder neck incision, I usually will try them on alpha blockers, see if that makes any difference. It can be used kind of as a diagnostic method as well. Now, there's another question from the comment section, which is what can be the best management for a BXO, or which in women we often call lichen sclerosis. So I treat a lot of lichen sclerosis in my patient population. I have a lot of women who come in, and they're often misdiagnosed. It's not always picked up. You know, they complain of vaginal pruritus, discomfort, and when examining them, it's usually involving the external genitalia, but sometimes it does, as Dr. Corcus mentioned, it does extend into the vaginal mucosa, the labia minora, the clitoris. It can cause clitoral hooding and actually clitoral phimosis in women as well. So I've had pretty severe cases of clitoral phimosis from lichen sclerosis. And the initial treatment should always be steroid-based treatment options. And I often either do a biopsy myself or refer them to dermatology, because they have, they're a lot more comfortable using all kinds of different steroid. So that really is the basis of treatment of lichen sclerosis. Now, if the lichen sclerosis is responsible for stricture, then obviously the stricture has to be addressed, but concomitant with proper steroid application post-op. Dr. Corcus, I don't know if you have experience with that as well.
I have experience with it. It's definitely a complicated field, very difficult, specifically when you do surgery on these patients. You know that you are not going to cure the disease by itself. So even to put some corticosteroids on the recent surgery is never very good in general. So it's a very difficult field. I don't think that anybody has the answer. It's something that you have to take with caution and time. And again, good participation of the patient. Local hormones could be helpful also in some patients if they are postmenopausal.
Good. Very good. So we don't have any more questions from the audience. I had a question, Dr. Corcus. I'm trying to refer back to your presentation. So in terms of one of the challenges I've encountered is actually being able to visualize the stricture, and it's oftentimes not something that I'm able to do. I often will try to do avoiding cystourethrogram, but as we know, women have a much more difficult time voiding in these settings. And so oftentimes you may be able to fill their bladder, but it's difficult to get a voiding phase study. And not all of these women will have undergone a suprapubic ahead of time. So how often will you get a suprapubic in order to plan beforehand?
I don't think that it's a common indication. I think that most of the time, you're able to push a urodynamic catheter, 5 French urodynamic catheter in the bladder, fill the bladder with dye, and take your pictures in standing position with the C-arm in standing position. Most of the time, it's possible. I never had to face a case where I was not even possible to put a very, very tiny catheter. I think that it's certainly possible. This time you have to put suprapubic catheter, because most of the time, if you're not able to put a 5 French, most of the patient is in retention. I have also a question for you, if you want, just to conclude, which is a bit of mystery for me, is when you do a uretroplasty, and specifically a buccal graft uretroplasty, or a ventral, even more ventral uretroplasty, how do you manage and how do you explain that most of these patients are still continent? I never understood how this patient could be continent when there is so much sclerosis on the urethra, and the ventral part has been operated and expanded.
Right. I I think the flaps that I've most commonly used and that are the Blandy flap, and it's really for distal strictures, right? So I usually don't cross past the sphincter. So, and I've used it mostly for younger women with healthy vagina and no associated atrophy, etc. Now, the times I've done, as I mentioned, the graft urethroplasty, I've used a dorsal approach. Yes, it's an interesting, because I've had good continence, and it's true. You wonder, well, how is that possible? And I don't know if it's necessarily related to the anatomical omega-shaped sphincter, and so that when you're addressing it from the dorsal area, you're preventing significant destruction of the sphincter. I'm wondering if that may be the explanation, but very theoretical. I'm not sure.
Okay, I think that we'll reach our limit. I think that, again, if you have any questions to send us, we'll be very happy to answer by email or through the ICS website. Thank you to everybody for this nice session.